So first of all, thank you for this amazing introduction, and thank you, Dental XP, because really, I guess that education is something that has to be carried on in a professional way, and the Dental XP family is doing great, spreading education worldwide. Thank you for this invitation. Let's go directly. I come from Rome, Italy. David told you about my apartment that is on the left there, on the top. And, you know, even if I spend most of my time in the office, unfortunately, but anyway, this is my life. 50% of my time spending with the patient, taking care of my patient, 50% developing new protocol, mostly based on digital stuff. So right now, I have more than 10 years of experience with the guided surgery and guided prosthetics. And we start with the small cases up to the most challenging cases. 10 years ago, working with digital was something for sure not worthy. It was really crazy because the digital workflow at that time was very poor. However, in less than 10 years, digital has become a sexy topic. And that's why I was recently invited to open the AO Academy on this topic. So really, the world is changing. We are paying more and more attention, merging together the surgery and the prost. And first of all, digital is the best way to put together the two parts of the same medal that are so important for the final results. So we started at that time, this is a very old case, with the anterior zone, because we didn't trust that we could carry on full arch cases. However, facing the anterior zone is not a simple case, particularly when there are some teeth that need to be extracted, because everybody knows the problem related to the implant positioning, the implant depth, grafting or not grafting the sides. But anyway, we try to merge our conventional experience with the digital workflow, because for sure at that time, it was not a streamline. It was plenty of drawbacks. However, what we appreciate immediately is that the true advantage of working with guided surgery is not drilling through a bushing, but planning properly the implant positioning with a prosthetically driven fashion. And most of all, fabricating in advance what will be the final prosthetic contour. So we start immediately from the prefabricated provisional to deliver the ideal shape that we want to deliver in the final step. Because it's the time of the implant placement, the right time to affect the biology and carving the soft tissue and guiding the healing of the soft tissue. And that's why we started to develop a new concept, that is the prosthetic scaffolding. That is something that is not new at all, but is something that is still tricky to understand. When we place an implant and we deliver immediate function, we have the great option to guide the soft tissue healing around the prosthetic contour. So we need exactly the right amount of acrylic, because I don't want to grab space to the soft tissue. The soft tissue is really the key. And over time, we start to follow up this case. 1 year, 3 year, 5 year, 7 year follow-up. And the soft tissue is still there. And the prosthesis that we deliver resemble exactly what we deliver the day of the surgery. What is important is not only the shape of the soft tissue, but also the function of the soft tissue. Because I don't want to experience any bleeding. An healthy interface means something that is pretty pink. That's why we started to investigate this critical interface in order to understanding if we can find the magic number. And that's why we started to recall several of our patients, and we started to measure with the CBCT all the pontic sites where flossing didn't cause any bleeding. But we'll come back on this point. That's for sure very, very important. So the soft tissue can guarantee over time that the bone will remain here. So the soft tissue interface is the critical zone. Regardless if we are going to embed our prosthesis into the soft tissue or we are going to float onto the soft tissue. Another amazing concept, the soft tissue-driven implant treatment. And I was so wondered when finally, working with the software, I was able to plan the implant positioning according with the ideal running room, with the ideal architecture of the soft tissue. Because this is the key when we talk about aesthetics. We need to fit this running room properly. If we don't fit the shape with the porcelain, it will be not enough to deliver a beautiful porcelain to accomplish the aesthetic demands of the patient. That's why we need to develop this critical zone in the ideal way. Because we are challenging the nature. We are challenging the critical zone that is in between the bone and the prosthesis. So if we want to go into the soft tissue, we need to reshape the soft tissue properly in a consistent way. And we need a rationale that is a biologic rationale and a prosthetic rationale. So let me give credit to David Garber and all the team, the Atlanta team, because they foreseen the problem several years ago. And this statement really is guiding my approach every day. Because we are delivering implants in very young patients. And if we don't take care properly of the soft tissue, augmenting the bone is not enough. It's not enough at all. So when the soft tissue is missing, we need to stage the surgical implant placement. When the soft tissue is a critical part of the treatment, we need to try to deliver a bloodless surgery, because we don't want to give any injury to the soft tissue, to the periosteum, to the blood supply. And even we are developing this concept starting from a single tooth. It's a very critical situation because if you look at the roots, they are very close to each other, so the bony peaks are very tiny, and the periodontal attachment of the adjacent teeth is very fragile. So in this case, we need to stage because we want to develop a nice environment that will be made by bone and soft tissue. When the soft tissue is there, what currently we are doing, and this is the latest proof of concept that I'm developing, is carving the soft tissue into the software. Because again, I don't consider guided surgery or the laboratory software are something that is only helpful to deliver a nice prosthesis. We have the great chance to manipulate the soft tissue in advance, because we can take, with an intraoral scanner, the impression of the soft tissue. And we can carve the soft tissue ideally, and we can fit this space with the proper prosthetic contour. Because when we are in the surgical theater, we don't have time. We don't have time to take care of this small detail. And again, when we deliver immediate function, that is the time to deliver the proper prosthetic contour. So going back from the prosthetic software to the surgical software, this means guided implant positioning, in which the prosthesis can confirm or not that the implant that we have planned is in the right position. So implant is a mix of technical limitation, anatomical limitation, that needs to be considered. So we can go back and forth from the prost to the surgery. And we can adjust the implant positioning in order to fit what will be the ideal prosthetic contour. So this going back and forth is really the key. It's better to spend more time in advance than later on. And regarding the bloodless surgery, let me show you this latest protocol. So what we did is planning the fully digital case. So everything has been virtually planned, the implant positioning, the prosthetic contour, and now also what I'm doing with this microblade is guided by the prosthetic contour. Because as I told you, I want a bloodless surgery. Placing the implant in the stereo zone is something very worthy. We are going to publish 10 years follow-up with the use of guided surgery in the static zone. Because the difference between succeeding or getting a failure sometimes is a matter of less than 1 millimeter. So be accurate is for sure the key. Be accurate and meticulous in our treatment plan. So after implementing the soft tissue and the bone, we can place our implant. We can deliver immediately a digitally fabricated crown and waiting for the healing of the soft tissue. And what we can do is a stressless surgery. Because if we plan meticulously in the virtual world, we can simulate what the patient has lost. The tooth before the surgery and after the surgery. And it's amazing because new concept, new biologic concept can be developed from this type of approach. Because the 3D implant positioning can affect the healing of the bone. Placing an implant closer to the central incisor in case we have a tiny bone peak can increase the width of this tiny bony peak. And this will support the papilla. So guided positioning, guided surgery, guided prosthesis. So again, it's a matter of understanding the digital working and all the new evidence that can pop up from this way of approaching the modern implant dentistry. But let's try to apply what I quickly show you for a case like this. Because this is a case of terminal dentition. So right now, it's very easy to state, okay, let's take all the teeth out and place a couple of All-on-4. Is this the solution for all the patient? Moreover, most of the deformity, when we treat the full arch patient, can be addressed with the proper prosthetic workup. Because when we talk about a terminal dentition, we talk about failing teeth, but we talk also about deformity of the bony crest that are related to the bone resorption or can be related to the bone supereruption. So, which is the right amount of bone that we need to carve off when we take these teeth out? Are you 100% confident that we really need to take the bone off instead of maintaining the bone? This is the tricky part of the digital workup, because with the software we cannot manipulate properly the mandible. And this is the big limit. The digital cannot overcome the knowledge of the fundamentals of implant dentistry. Forget it. It's not a shortcut, the digital. It's something that is far from being easier, particularly when we deal with the full arch. And most of the problems are related to how to import in the digital world, in the virtual world, all the information of the patient. Because all the fancy stuff in which we take a photograph and we try to overlap, we are going to overlap a bidimensional information into a 3D volume. And this doesn't make sense for me. It's just something that can be informative for the patient, but cannot be affecting in determining my decision-making. That's why has been recently accepted this protocol. It's a nice name, Laughing Scan, and this is what we are doing so far to import the information of the smile line of the patient into the software. So we don't use any photograph. We just work with the 3D, taking the scan of the patient while the patient is laughing, is keeping the smile on. The latest CBCT equipment can allow to gather the information of a large volume in less than 15 seconds. And so far, we didn't experience any artifact related to the movement of the patient that could affect our decision-making regarding the implant positioning. So we need to import all this information in the virtual patient in a 3D way. The 3D facial scanner, for sure, can be the key, but are still cumbersome and complicated. And we need to still merge the conventional way of working with the digital way of working. Now we are taking the scan of the patient with the patient in occlusion because we want to import the information of the current occlusion of the patient or the information related to the centric relation of the patient into the scan. At the same time, we still need to merge the conventional way of working because this wax rim cannot be taken by a software. And what we can do is dealing with the digital in order to understanding where we need to implement the soft tissue and where we need to remove the soft tissue and even the bone sometimes to create a smooth interface, easy to clean. So this is a very difficult case because every time that we have a terminal dentition, we have a tooth movement. But these teeth are plenty of information. And first of all, they can increase the accuracy of the guided surgery just because we have these few dental units that can be used as a rest for the surgical template. So first of all, we didn't open a flap before drilling through the anchor pin. Then we open a flap to save the keratinized tissue. And again, we replace the template in the patient mouth. Guided surgery doesn't mean shut down the brain. It means taking the proper decision-making according to the surgical difficulty of the site. The two anterior implants are two fresh extraction sockets. Therefore, we decide to plan for a pilot drilling, while the two posterior implants can be delivered with a fully guided approach. On the left side of the patient, we open a flap because we need to fill the concavity of the soft tissue and implement the bone, while on the right side, with the mucotome, we just remove 4 millimeters of keratinized tissue in order to go through the soft tissue with the implant. So working with a guided approach, again, doesn't mean working all the time with the flapless approach. It means customizing the decision-making regarding the handling of the soft tissue in order that our implant will be properly surrounded by the proper amount of keratinized tissue. One of the great advantages for the immediate function is the possibility to under-prepare the implant site. And even this is a new concept. That implant has been stuck into the bone with an insertion torque measured through the sleeve of about 70 Newton per centimeter. So we increase, particularly in the maxilla, the insertion torque in order to find the proper primary stability. Then we go in the front, and you can see that under-preparing means with just one drill, we can follow up what we have done with the pilot drilling, maintaining the prosthetically driven direction and placing the implant, even in this case, with an high insertion torque. I still didn't remove the teeth because this is a source of information. Because I can measure the distance between the incisal edge and the implant platform in order to decide in advance what will be the ideal depth of the implant in the anterior zone. At this time point, we can remove the teeth and we can build up the bone in the frontal area. Because if the bone is missing, we need to augment the bone. This is the only case in which I deliver immediate function and simultaneously I deliver a bone augmentation, because in this case, it's just missing the bone in the horizontal fashion. And this is the prefabricated prosthesis that now can be fit onto the temporary abutment. And please focus your attention onto the pontic side, because you can see that this type of prosthesis doesn't fit properly, not because the temporary abutment engage the prosthetic contour, but because the prosthetic contour can touch some part of the bone that we need to reshape. So even in this case, working with a minimal invasive fashion in order to reshape the bone where we need and augment the bone when it needs to be augmented. And again, the occlusion is the key. So the patient can bite we can find out the pre-planned occlusion, and at this time point, we can fix the temporary abutment. The prosthesis is the ideal scaffold. It's the ideal scaffold that we need to take into consideration, because I don't want that the bone can touch the prosthetic contour. And moreover, I don't want that the distance between the prosthetic contour and the bone will be too tiny. Because when you see that there is some bleeding at the soft tissue interface, it means that not that the patient is not cleaning properly. It means that there is not enough soft tissue to protect the underlying bone. So augmenting the bone horizontally with a sticky bone, you have seen an amazing lecture today. Placing a membrane, and then what we do in order to try to improve the quality of the soft tissue, the quality and the quantity of the soft tissue. On the top of the membrane, we used to place a xenograft material, a xenograft soft tissue substitute, and a couple of PRF membrane. So if we focus on the single step, first of all, prosthetically driven surgery. If this is the ideal contour that will fit the aesthetic demand and the functional demand of the soft tissue, I don't want to touch the prosthetic contour. I'm going to touch the bone. Second part, when the bone is missing on the horizontal fashion, we augment the bone all the time and we deliver the function. When the bone is missing on the vertical horizontal fashion, we never deliver the provisional, unless we use an interim implant to support the provisional. Immediately, we try to increment the quality of the quantity of the soft tissue, using a soft tissue substitute like the mucograft covered by PRF membrane. And we suture on the top. This is the outcome of the surgery, and this is what happened after 45 days after the main surgery. It's not perfect, but we are on the right track. You see that is missing something here, just distally this implant. But I don't want to disturb the healing. The soft tissue and the bone interface are still recovering. We need to wait. We need to wait at least 3 months. And after 3 months, we remove the provisional. I never unscrew the provisional up to 3 months. Every time that you unscrew a provisional that is embedded into the soft tissue, you create a trauma to the interface. And this is what we achieve after 3 months. You see how with the prosthetic scaffold, we can really manipulate the soft tissue, and we can implement the soft tissue in the horizontal fashion and in the vertical fashion. At this time point, I take an impression, not because I want to deliver the final restoration, but because I want to implement the soft tissue once again. Because you see the defect that needs to be fixed. Particularly, I don't care about this papilla. It's very thick. It can be easily fixed, but I care mostly about the space between the cuspid and the lateral side. And again, we can take the impression of the implant. We are working on a new protocol to take the full arch impression with an intraoral scanner, but you can use the conventional impression and then give the impression to your technician that will use a laboratory scanner to scan the model of the patient. And again, what we are doing right now is carving, ideally, once again, the soft tissue, now that the soft tissue and the bone is completely healed. And we can deliver again the final interim prosthesis, the final provisional, that will guide, once again, the soft tissue interface through a prosthetic manipulation. And this will be the shape that we are going to deliver with the final restoration. This type of protocol has been published. I published with Peter Moy in 2014 in the Clinical Implant Dentistry and Related Research, and we named this protocol Digital Assisted Interface Reconfiguration. Let me show you the second part of the treatment. So this is the second provisional set, and you can see that we still need to work because now we have achieved a bulky soft tissue interface. So now is the time to manipulate the soft tissue surgically and prosthetically in order to surround the prosthetic contour properly with the soft tissue interface and guarantee over time the success of our prosthesis. So you see that in all the cases we try to deliver a bloodless procedure. You see how much close are the two implants aside, so we never disrupt the very fragile soft tissue around the implant. The bone is still touching, so with the piezotome we are going to remove the bone properly. And then we start with the upper jaw, fixing the soft tissue deficiency in between the implant and the cuspid. So a split thickness flap in order to create a pouch and increase the thickness of the soft tissue in the vertical and in the horizontal height. With this type of deficiency, the autogenous soft tissue is still the gold standard. There is no substitute that can work as the autogenous soft tissue right now. Now we are ready to fix properly the graft and to deliver the second set of provisionals. Here we go. The function needs to be addressed all the time when we reduce the implant number, so particularly all the centric movement of the mandible needs to be addressed because the patient has been wearing his failing dentition so far. So this is what, two shots of the surgery, you can see that we use autogenous soft tissue grafting, mucograft, PRF, in order to reconfigure the soft tissue once again. This is the day of the surgery. And I don't care about this pace, because when you are acting with the pressure onto the soft tissue, you need to leave some leeway space for the soft tissue spread and grow. And this is what happened. Now we are ready to deliver the final restoration. The soft tissue is completely reconfigured. The final restoration is exactly the copy of the provisional, of the second set of provisional. And let me give you my advice. This has been recently published in a beautiful systematic review on the Journal of Prosthetic Dentistry, and we published the same in the British Dental Journal. So the monolithic translucent zirconia is a very fascinating way of approaching the restorative part of the implant dentistry. However, the high success rate reported in the literature should be considered with cautious optimism. First of all, because we have a limited number of published studies. Small sample size, short follow-up, up to 5 years, and very low rank of hierarchy in the evidence-based research. So the results are very, very promising with the monolithic translucent zirconia, but still we cannot talk about the evidence-based option. That's why we are still working. When we try to work with the monolithic, now we are conducting research with the new monolithic zirconia, but up to date, all the cases that we did, we use full-strength zirconia, and what we did, we carve off the aesthetic and the functional part in order to customize not only the aesthetics, but also personalize the phonetics and the occlusal function. So the final restoration is an hybrid restoration, not because there is something pink, but because it's composed by full-strength zirconia in the molar and premolar side, and lithium disilicate veneer in the aesthetic area. This is a very important part in our experience because it's so difficult to customize the phonetics and adjust the phonetics when we work with the monolithic zirconia. We still prefer to customize the aesthetics and the function with this type of approach. We did not experience any fracture. And this is mostly related to this number. We are going to publish a new manuscript in which we focus on the connector size. The pristine guideline for the zirconia framework talk about 9 millimeter minimum of connector size. In this case, in which we are going to cover the aesthetic part, we have a connector size average that is more than double the pristine guideline to avoid the fracture. So, still again, really, I'm a fancy digital guy, but sometimes we need to step back and wait for a longer evidence, particularly when we need to take care of patients that are becoming more and more demanding. This is the final result. The failing dentition, no pink ceramic, something that resembles a periodontal age dentition, and is very well accepted by the patient. Because at the end of the story, the patient wants to understand where they have to clean. Addressing the aesthetics and the function means addressing the vertical dimension. And working with 2 sets of provisional is the best way to deliver the ideal restoration. Most of my patients with terminal dentition, particularly the female patients, are suffering by TMJ problem. We need to address this problem. We cannot skip the fundamentals of implant dentistry just because we work with digital. All the implants are properly placed in order to make easier the maintenance. All the implant. I don't want an implant in the middle. Moreover, all the implants are placed with a parallel fashion, and even in case I tilted the implant as in the upper jaw, I tilted the implant in order to compensate the angulation of the implant properly with a multi-unit abutment. This was the pristine situation of the patient, and this is the final. So that's why I told you that it's so important planning properly the case, because I didn't augment the bone here. When you see a bone ridge like this, we immediately talk about and start to think about augmenting the bone. Are you sure that this is the solution for all the patient? This could be the solution if the centric relation of the patient is the proper one when the patient knocks the door of your office. It can be the solution, but not in this case in which we have a vertical supereruption. So the soft and bone tissue interface needs to be completely reconfigured. That's one, once again, planning is more important than treating and scanning the patient. And this is the final results in which, again, the function resemble the aesthetics and vice versa. Don't be worried about the smile line. It's the percentage of patients with a short lip at this age, it's 0. For a patient, cleaning properly and maintaining properly this type of interface, sometimes it's easier than flossing around the bulky pink ceramic that doesn't guarantee the maintenance over time, just because it's flat. So again, the bone set the tone, but the soft tissue will determine the success over time. So be meticulous in the planning of this critical part. Just to give you some numbers, because we are all tired, is it reliable to maintain such architecture over time? So this is what we did. We recall all the patients, usually with the schedule every 4 to 6 months, according to the dexterity of the patient. What we did, we measure in the CBCT scan all the pontic sites that didn't experience any type of bleeding. It was a massive, huge work, because we investigate more than 200 pontic sites, and we took more than 1,300 measurements on the buccolingual side and on the mesodistal side. And what we achieve in this box plot graph is a consistent number. And this is very interesting, because we need magic number. We love magic number to guide our way of working. What we found, and we named it pontic biologic high, in the maxilla we found out a soft tissue height of 2.32 with a standard deviation of 0.57. And you see that is in the mandible, it's more or less the same, is not statistically significant. So at the end of the story, we found the mean between the upper and the lower of soft tissue high of about 2.26 plus minus 0.60. And if you look at the box plot analysis, all the measurements were very close to the average. So it was a very consistent result. Another case, planning everything in advance. A crazy speed up of the soft tissue integration, because I told you at the beginning that this is the time to affect the healing of the soft tissue interface at the fresh extraction socket, air, and at the pontic site. And we can affect positively or negatively. So it's so important to handle the acrylic in the proper way. Even in this case, the lacking of keratinized tissue, the lacking of volume of keratinized tissue was addressed with the same protocol that you have seen for the first case. Terminal dentition, normal dentition. It's not a matter of material. This is composite. Which type of interface is my favorite? The ridge lap, I don't like it. I guess that I put in the presentation a case in which there is this type of ridge lap. The ovate pontic is too aggressive. You go too deep with the tip of the pontic. This is the biologic pontic that we published in 2014. You can see that we have a couple of shapes. We have an external shape that is higher at the apex. Then the shape and the volume slope toward the lingual side. And this is the less aggressive shape because it goes less deeper. So it allows to remove less bone. There is plenty of evidence on the role of this type of pontic. We just modified the morphology. And this is, again, another case in which we treat the interface in the same way. What I want is not an expensive solution. Again, this is composite. It's pretty sustainable by all the patient. What is important is the emergence. When I talk about the interface, talk about pontic, and I talk about a running room, because the healthy interface at the pontic site will affect positively or negatively again the outcome at the implant site. So why guided surgery? Because I really want to integrate these two parts. I already presented this case last year because I told you that we are treating more and more young patients. This is a 40-year-old patient. It's not her fault, it's not her problem if this lady has a nice myline. It doesn't make sense to carve the bone off all the time. What is important is bringing into the software the proper prosthetic contour because we need the proper information. Don't be in a rush. Even if with the latest digital workup, we can really scan the patient immediately and then merge the information coming from the treatment plan later on. Even the implant positioning, the implant don't perform in the same way. In this patient with high smile line, we need to carve the bone off. To carve the bone off, we need to go deeper with the implant platform. So that's why, again, the software is the best way to put all this 3D information together. Lip support, cheek support, buccal corridor that needs to be filled. If you cannot fill the buccal corridor because the diameter of the maxilla is reduced, you need to augment with the bone the lateral wall of the maxilla all the time. Because otherwise, the horizontal cantilever will affect the outcome of the overall implant-supported prosthesis. And again, let me reinforce this message, because trust me, placing the implant through a bushing is exciting, but it's not the big advantage of working with this type of stuff. Even in this case, we just treat with one provisional. It was an easier case because the central relation and the vertical dimension was pretty maintained. And don't be worried about a flat interface, because if you treat in a gentle way the bone and the soft tissue, you can transform a flat interface in a scallop interface. And again, it's not a matter of restorative material right now. You can use zirconia. We have widely published on the way of treating zirconia. And I want to show you that what we put in the software as prosthetic contour, it's what we deliver at the end of the treatment. So this is what I mean for working with the hand in mind. Before and after. And the sexy smile of the patient. The madam is very happy. The husband is not so happy because he spent tons of bucks for her smile. I'm very happy. 7-year follow-up for these results. It's 7 minutes, eh? It's a long journey. Do not forget that when you float on the soft tissue, this is an option. It works very well. The first full arch that I did was 1997, and I delivered something floating. It's still working properly. But if you go into the soft tissue, you can stimulate the biology. And the bone tissue can remain there because the soft tissue has a cushioning effect, so can stimulate and can transfer the information and the loading from the prost to the bone. Why using guided surgery? You know, the Atlanta team is a great example for me because it's the perfect mix between excellence in clinical delivery and excellence based on scientific approach. And I'm trying to imitate them. That's why I always try to validate this new stuff. This is the first randomized clinical trial that has been never conducted to demonstrate what is the best approach, the guided approach or the conventional approach. We published in 2014 on the European Journal of Oral Implantology. Let's go quickly to the final results and conclusion of this type of work. So, for sure, the learning curve is so important. High implant survival rate with both approaches, but in the study design was that all the patients have been planned with the software. Then they were randomly allocated toward the guided group or the conventional group. So even just planning with the software, planning the virtual surgery will increase your clinical performance. The immediate implant placement and the placement in the fresh extraction socket is more predictable. and that we experience a more favorable trend. If we look at the accuracy of the guided surgery and we try to compare with the accuracy of our hands, there are few manuscripts. And what I can tell you is that there are 3 manuscripts that investigated the mistakes, the lack of accuracy between what we think that is good in terms of 3D positioning and what we deliver in the patient mouth with our conventional drilling. And you know, which is it, the results that the lack of accuracy of our hands is the same of the digital stuff. So why we should expect 100 of accuracy from the guided surgery when the current gold standard is not accurate at all? So again, it's a matter of understanding what is good and what is not good. The clinical success is a mix of common sense, experience, and knowledge. That's why for the full arch reconstruction without any teeth, the double scan protocol in which we scan the patient is still the gold standard. Same approach. We never skip one step. The lower jaw is different because we have a failing dentition. Whenever I have a failing dentition, I love to keep strategic teeth. Because strategic teeth will allow to rest the surgical guide on the stiff surface. And even these results have been published last year. The tooth-supported template are more accurate than the bone-supported template, and more accurate than the mucosa-supported template. The day of the surgery, before, and we just want to see better. This is what will allow the digital, will allow to plan a soft tissue grafting in advance, because now I'm working with an additive grafting. And I can do the same in the patient mouth. All the information of the provisional can be scanned and imported in the final restoration in terms of prosthetic contour and in terms of design of the framework. And another upper and lower case in which the strength of the zirconia dioxide is merged and fused with the reliability of the lithium disilicate. And now we are fusing together the two material with the low fusing porcelain. We don't bond anymore. As I told you, we are investigating the new translucent zirconia with a very high flexural strength. This is an example of the optical property of this material. And this is the final outcome with the upper and lower 3-year follow-up, the lower, and 8-year follow-up, the upper. Let me show you the last case. Is this case. Is there bone there? Are you confident that you can place an implant without any type of bone augmentation? What I'm learning every day is that I don't trust anymore the bidimensional planning. This was the patient. I love to personalize the treatment. And what I want that you focus on, that in the decision-making about delivering something pink or white, this is the key. The key is the position of this lip. And what I want to show you that without a prosthesis, The lip of this lady, of course, there is a collapse of the vertical dimension, but the lip of this lady is not so bad. If you're going to compare the lip with the Prost, with the lip without, we don't need a massive support, even if it seems that the bone is completely missing. This is because we need to personalize the treatment, because each treatment is different when we talk about full mouth rehabilitation. And it's amazing when we look at this CBCT reconstruction. Where is it, the bone? The crest is very tiny. Is it possible in a predictable way to place the implant? This is the graph. And you know, the big challenge is try to make as minimal invasive as possible this type of treatment, because we are treating more and more patients that are patients with a compromised medical disease. So we need to be minimal invasive. And that's why we plan for this patient a guided approach. The bone was not there, but we were able to plan 8 implants. 8. You see that we just elevate a very tiny flap, because I don't want to disturb the periosteum of this patient. For sure, I never load, but you can see the size of this implant. The pterygoid is 18. The implant laterally to the nasal cavity are 13. The front implant are 11.5. So when you tilt, you can find bone that sometimes we don't see in the conventional approach. And again, working with a bloodless surgery, even in the second stage approach, just building up the soft tissue where it's missing. And this is the case in which I never ever go into the soft tissue. But it doesn't mean that I want to deliver a pin porcelain. I can deliver a ridge lap interface that's easy to clean by the patient. And this is the final. Let me show you the follow-up of this case. This was the before. This is after. He's a 75 years old lady. We are maintaining the 2 elements, and this is the bone. Working with the upper doesn't care of the lower jaw. And what we did with this tiny laminate, we just recreate the function, the groove function, in order to guarantee the lateral movement of the mandible. And this is the final smile with the lip that is properly supported. 1 year, 3 here, 5 years. We are going to lose these 2 teeth. Let's see if you can do something. 7 years, 10 years follow-up. So we really need to think out of the box, because this is the great advantage of the guided surgery. We have lost some tissue over there. This is the last picture of this patient. But maintaining our implant doesn't mean grafting over time the implant. We can do a graft. It's a 10 years follow-up. And this is my beautiful patient that is growing with me. And this is what digital needs today: evidence, experience, and common sense.